A 78-year-old man presents with vague abdominal pain, new onset bloody diarrhea, and a significantly elevated serum lactate level. I am showing you an axial CT of the pelvis. Describe the findings.
Okay. The CT demonstrates a dilated, fluid-filled cecum and proximal ascending colon. There is diffuse, severe mural thickening with prominent submucosal low attenuation, consistent with severe edema.
What is the most critical and concerning finding associated with the thickened colonic wall?
Most notably, there are extensive linear collections of gas tracking within the submucosa, diagnostic of pneumatosis intestinalis. There is mild adjacent pericolonic fat stranding, though I do not see definitive portal venous gas on this slice.
Considering the patient's advanced age, sudden bloody diarrhea, and elevated lactate, what is the most likely etiology for this severe right-sided colitis with pneumatosis?
The clinical presentation and imaging findings are highly diagnostic of severe acute ischemic colitis that has progressed to bowel wall necrosis.
What is the most specific, yet often difficult to appreciate, CT sign of true bowel ischemia on a contrast-enhanced study?
All right, the most specific sign of true ischemia is a complete lack of mural enhancement relative to adjacent normal bowel loops. This directly reflects a complete absence of arterial perfusion to that segment.
Although this case involves the right colon, what are the two classic watershed areas in the colon that are typically most susceptible to low-flow ischemic colitis?
All right, the classic watershed areas are the splenic flexure, which lies at the junction of the superior and inferior mesenteric artery territories, and the rectosigmoid junction, where the inferior mesenteric artery and internal iliac artery territories meet.
If a patient survives an acute moderate ischemic event without requiring surgery, what is a known chronic complication that can develop in the affected colonic segment?
So, following a non-fatal ischemic insult, the bowel wall heals with extensive fibrosis, frequently leading to the development of a chronic fibrotic ischemic stricture that can subsequently cause large bowel obstruction.
How can you differentiate ischemic colitis from infectious colitis based solely on the CT appearance of the bowel wall?
If we look closely, it can be extremely difficult. However, infectious colitis typically causes marked mucosal hyperenhancement with a prominent target sign, whereas severe ischemia will show absent or poor enhancement. The presence of pneumatosis strongly favors ischemia.
How would you manage this patient as a radiologist right now?
I would place an immediate, urgent call to the general surgery or vascular surgery team to report frank colonic ischemia with pneumatosis.
What is the specific clinical implication of the elevated lactate in combination with the pneumatosis?
So, the elevated lactate combined with pneumatosis indicates irreversible transmural bowel necrosis. The patient requires an emergent exploratory laparotomy and bowel resection to prevent lethal peritonitis and overwhelming sepsis.